Good afternoon, everyone, and welcome to ALLEVIATE'S webinar series. Today, we will be discussing about a very important topic. As you all know, that ultrasound has become a big part of all our pain clinics, and knee is a joint which is like probably the commonest presented to all our pain clinics. So, the role of ultrasound in detecting the pathology involved with the knee joint. That's what exactly will be the crux of today's discussion. I'll keep it basically that we'll be discussing about sonar images and a little briefing about it. So this is me, Dr. Wiquar, consultant pain specialist at Elevate Pain and Spine Center at Hospital Bangalore, former consultant anesthesiologist at Aadhar Hospital, Kollam. So this will be the overview of what we'll be discussing today: joint abnormalities, cartilage abnormalities, tendon abnormalities, crystalline arthropathies like gout, ligament abnormalities like MCL, LCL, and other ligaments, BURSA and CYST. So in joint abnormality, the common thing which is presented is the degenerative arthritis or osteoarthritis, which is presented. And this is a picture again at your middle joint side, where you can actually appreciate the osteophytes. You can appreciate the effusion at these areas. At a very progressed arthritis, you can see extruded discs, the extruded meniscus, sorry. And this is the radiograph which compares with the medial joint area where your osteophytes are also quite prominent. Next, coming to joint effusion, this is in a flexion about 30 degrees. And here you can see the quadriceps tendon coming and attaching to the patella. You can see the prefemoral fat pad, quadriceps fat pad, your femur. This is the area where you can see the effusion, minimal effusion in this case. An anechoic area which you can appreciate. This is in the lateral recesses where you can see the arrow heads are pointing towards your patellar retinaculum, your patella. This is the femur, and that's the effusion which is present. Joint infection. This is a case of joint infection wherein this is post arthroplasty, that is after TKR. You can see that implant there. This is the femur, and this is pointing towards the space, the infected area, and you can have through transmission will be actually increased in cases of infection. In cases of articular bleeding, if a patient presents to us with osteoarthritis, not mandatory that the patient should have inflammatory or non-inflammatory fluid in that. It can also be a bleed. So it's very important for us to take the history properly. If the patient has had some fall, some trauma after which, and in cases of articular bleeding, that is the hemorrhage, the patient will have quite severe pain. So in this case, again, you can see that there will be mixed echogenicity. And synovial thickening commonly seen with all your inflammatory problems, inflammatory arthritis, where the asterisk in this case is pointing towards your synovial thickening, which will be seen like cotton balls. This is again a video in which, under all aseptic precautions, we are doing an arthrocentesis at the suprapatellar area, the BURSA area, where you can also see. Because aspirating through a larger gauge needle is difficult, we always use, in this case, I'm using an 18 gauge needle with a linear probe. You can see the needle there. The anechoic area, that is the bursal collection. Also, the fluid which you're going to tap out is also going to give you an insight about what could be the pathology. So that's very important. In this case, it could be inflammatory or non-inflammatory fluid, but whatever you're going to tap out, it is ideal to send it for an analysis. If the fluid color might be reddish or blood tap, it's ideally your intra-articular bleed which has happened. Septic arthritis is not something which will be, very frequently it will come to your clinic, but still the septic arthritis will be more turbid and different, brownish and reddish in color. Inflammatory will be more of yellowish, and in cases of rheumatoid arthritis, even a little whitish also can be tapped out. So again, cartilage abnormalities. This is in the suprapatellar area. We have given a proper flexion and we have taken. The arrows are pointing towards your cartilage defect which is present. the hyaline cartilage, which is very normal in the arrowheads, which you can see. So in cases of quadriceps tendon abnormality, something which is quite frequently seen, it is, it could be tendinosis, partial thickness tear, or full thickness tear. Partial thickness tear, you can see in this case, wherein your rectus femoris and all is intact, the arrowheads are pointed towards, whereas the, the posterior aspect, there is retracted ends of the vastus tendons, which can be appreciated in this. In cases of tendinosis, there will be diffuse swelling and swelling of the quadriceps tendon, but there's no thickness, associated tear which is present. In this case, again, where you can see a retracted end pointing out mainly towards a full thickness tear. Here again, we are seeing a full thickness tear, wherein a normal tendon can be seen with the arrows. It has been compared with a curved a radiograph image, wherein in the suprapatellar area you can see the avulsed end, and also the arrowheads in this case are pointing us towards the normal distal end of the patella, near the patella, that is your quadriceps tendon. In this case, again, patellar tendinopathy, wherein you have seen and your quadriceps area, and you translate it further, you see the patella. Furthermore, when you translate your probe, you will be able to see between the patella and your tibia, which is your patellar tendon, which exists, and that could be diffusely swollen up, like in the image above, or it could be that the distal end is more thickened, whereas the proximal end is normal, as seen in the second image. This is again a case in which there is your jumper's knee, that is your proximal end is, there is partial thickness. You can also appreciate the first fat part in this. The upper end is of the proximal patellar tendon is normal, whereas the deeper fibers are lost. There is a little partial thickness tear also at that, where your asterisk is seen. This is again patellar tendon partial thickness tear, wherein you can see a transverse and a longitudinal axis of the same thing. Small intra-substance calcification is also appreciated, and the tendon is normal on medial and lateral side, whereas central focal tendinopathy is appreciated in this case. This diffuse swelling of the tendon as well, of the proximal end. This is again a full thickness tear of the distal end, where you can see that distally near the tibia, you can see the thickened end of the tendon and retracted proximal end, and you can also appreciate the hematoma which is formed around this area. Few things which also can be missed out sometimes is small fractures of the patella also. In this case, you can see that there is cortical defect which you can actually, or a cortical break where you can actually appreciate, and it is also compared with a radiographic image. In cases of crystalline arthritis, arthropathy like gout, you can see in this case where you can see the deposition of monosodium urate crystals in the meniscus. Rheumatoid arthritis, inflammatory cause, where you can appreciate your erosions, which is very common. Enthesopathies, enthesitis can also be there. Effusion also can be there. So in this, the arrowhead points us towards the erosions which are present, and there is also effusion around the area. Coming to medial collateral ligament abnormalities, as you all know, medial collateral ligament has a deeper and a superficial layer. In A, you can see that there is the superficial component is intact, whereas the deeper component, that's a meniscofemoral component, there is a detachment, and there is asterisk points us towards a hematoma present at that area. In B, you can see that the deeper component is fine, but there is a hematoma and a detachment of the tear of the proximal end of the superficial component of the MCL. In these cases, you can see the arrow depicts your bony avulsion, which could be present with deep superficial and deep components of medial collateral ligament. This is again a case of medial collateral ligament calcification, which is compared with even your radiograph on the right side, and there is a big calcification which is present, and also there is thickening of the medial collateral ligament. IT band, again, of what all discussions has happened till now, you have to realize one thing, that when a patient presents to you at any age, it is not only arthritis which could cause the pain. So giving an intra-articular injection may not suffice. It's always better to do a complete a scan wherein you can pick up the medial lateral, the superior area, come down below the patella, and infrapatellar, suprapatellar areas. All these assessment is very important. One of the component in these cases again is that is your IT band syndrome or IT band thickening. In the image above, you can see that the IT band is thickened distally and the proximal end is normal, whereas the distal end, or the image down, there is a diffuse problem in the whole IT band. And this is also one of the cause of where your IT band comes and attaches to your Gerdy's tubercle on the tibial plateau. So it's a cause of your lateral knee pain. Again, this is your suprapatellar bursa, in which you can see that it's a transfer scan where you can see the effusion, which is quite an anechoic area, and you can see that there is your quadriceps tendon right in the middle. This is very important for us to appreciate before we actually put in a needle, because at our center we also do Botox, we also do hyaluronic acid supplementation, visco supplementation. So it's always better to visualize it, and for all these cases, it is always better to inject in a transverse plane, and visualization of the quadriceps tendon in this case becomes very, very important. There's again a video in which you can see the bigger bore needle and synovial thickening. That's the reason why I placed. You can see that cotton type of the way the synovial thickening looks. It's always better to aspirate it, send it for analysis, and then you can also deposit whatever you are planning for. It could be a corticosteroid injection, it could be a hyaluronic injection, it could be Botox injection in cases of progressed arthritis. We also supplement hyaluronic acid with all our full radio frequency ablations, which we are doing at our place. Most of these procedures, you should understand that even a linear probe is sufficient. But sometimes the patient presenting to us might be 120, 130, 140 kgs also. In these cases, it's difficult to actually appreciate with a linear probe. So it's in this, why I have put this images, because this was a female patient of 135 kg, and linear probe, I couldn't appreciate anything. So you can see that there is a needle coming there, and this is a curvilinear probe image. So it becomes much easier for us to locate the area because we are depositing it in that, precisely we are depositing into that bursa. So it becomes much easier. Another cause of infrapatellar pain could be your infrapatellar bursa, which could be superficial and deep. In this case, you can see that there is the open arrows are pointing towards your superficial bursa, infrapatellar. In this case, you can see a longitudinal and a transverse plane scanning of an infrapatellar deep bursa. Again, it could be aspirated, and probably it could not be just arthritis, and it could be that even bursa injection helps these patients a lot. Another cause of medial joint pain is your ANSERINE bursa. Very important for us to appreciate it. And the probe, when you're doing your medial joint, you just translate it a little down, and the probe has to be, the lower end, the distal end of the probe has to be translated or switched over a little more anteriorly, wherein you can start to see the ANSERINE bursa. Again, a cause of medial joint pain. It will not be the pain. The patient may not complain of pain in the medial joint area, but it will be more distal to that. So that is also one thing we need to remember when you are actually doing or you are considering any medial joint pain. Meniscus tear can also be appreciated in ultrasound. In this case, you are seeing a simple horizontal tear, a simple vertical tear, and a complex tear. Complex tear also going down to your articular surfaces. In this case, you are seeing an extruded meniscus in a case of progressed arthritis also. Another cause of posterior joint pain could be your Baker cyst. So that has to be, this is basic a schematic diagram demonstrated also as a diffuse swelling on the posterior aspect and a surgically opened how a Baker cyst looks. So your any pain posterior joint, the assessment of Baker cyst has to be done, and it can be very beautifully also appreciated. It is between your semimembranosus and medial head of the gastrocnemius, which you can find this. This is again an aspiration or the needling technique where your needle is into the bursa. And, this is an echogenic needle with the texture could be appreciated very nicely under ultrasound. If at all it's available, you can this could be always considered. All your stimoplex needles are all echogenic needles as well. This is again a case of parameniscal cyst in which the meniscus you can appreciate where your arrows are and the arrowheads are pointing towards a parameniscal cyst. You don't inject anything in this, but you can aspirate it. This could also be a cause of your pain. Mostly, I've had a few patients in which we have aspirated and the patient does feel better. This is again a case of loose body, below which you can see the acoustic shadowing, which can be present. Very important needle technique. This could not only be for knees or any other interventions is if you're using a linear probe, it's not always important. This was a case of scapulothoracic bursa. So important that you play safe also, and because very close to your pleura, you can bend the needle. The needle can be bent so that it is parallel and seen very nicely and safely can be used for your interventions. Hope that was helpful, and these are my references. Thank you.
Thank you, sir.
Yeah, Satish.
Yeah,
Sir,
thank you.
Yeah, Satish, please ask.
Sir, like for visualizing meniscus,
Yeah.
how we have to place the probe, sir?
Just like how you are, the knee inflection a little adapted and placed, and you can just like you're visualizing for your medial joint, you see your MCL. Just below that, you will be able to appreciate your meniscus as well.
Okay, sir. Okay, sir.
Yeah. Any other doubts you have, Satish?
No, sir. No, sir. That's all.
Okay. Okay.
Thank you, sir. Thank you, sir.
Yeah.